So thank you so much for inviting me to talk on your course today. I'm sorry I can't be there in person. My name is Dr. Sophie Taylor and I'm a consultant in palliative medicine at the Royal Wolverhampton NHS Trust. I work primarily in the acute hospital setting and I'm frequently involved in supporting patients who are under the care of ENT as inpatients. I also work very closely with my palliative care colleagues who are based in the community and hospice settings. And we work very closely to support the transitions across different community settings with this patient group who can often have very complex clinical and social situations. So during this session, I'm going to focus on a real life case I was involved with. It was about a year ago now. And I was involved over the course of the last few months of his life. He had several admissions to the acute hospital setting under ENT and then finally medicine right towards the end of his life. And the aim is really to apply some of the learning outcomes to this real life setting to hopefully increase an awareness of why these topics are important and the value of team working between our specialities. So Mr. X was a 55-year-old gentleman who had had a previous medical history of a hypopharyngeal SCC. He'd undergone surgery followed by radical chemoradiotherapy. His treatment was unfortunately complicated by a persistent large tracheoesophageal fistula. And so all of his medications and feeding from that point had been via his rig. And that was back in about 2014, 2015. In 2025, he sadly developed a new left base of tongue SCC and was initially started on palliative chemotherapy in May 2025. He had a past medical history of alcohol misuse with evidence of alcoholic liver disease on ultrasound scans. And he continued to take alcohol via his rig. He had quite a precarious home situation with periods of homelessness, but at this first presentation he was living in a property, a house of multiple occupancy, and he communicated primarily by writing. At this point, his prognosis was months, so we would say, using our gold standards framework, we would call this GSF green. So not long after starting his palliative chemotherapy, he was admitted to hospital under ENT with oral bleeding and a severe pneumonia. He was referred to the specialist palliative care team at this point to help with some symptom control issues and to start some advanced care planning conversations. So his physical symptom issues were quite significant facial pain, secretions and intermittent bleeding. The ACP decisions that really needed to be looked at was thinking about the risks and benefits of ongoing systemic anti-cancer treatment and what we should do in an emergency situation and what our escalation plan should be. There was also a number of psychological and social issues that became apparent. So the patient had a lot of emotional distress about his altered facial appearance. He had now been evicted from his property and essentially was homeless with quite complex and evolving healthcare needs. And there was ongoing alcohol misuse, which was ongoing in the hospital setting as well. So in terms of bleeding for Mr. X, on this admission, he went for a CT angio, which identified a bleeding point that they were able to embolize successfully via interventional radiology, and he didn't have any further bleeding on this admission. In terms of secretion management, at this point in Mr. X's illness, what he was struggling with was really sticky, thick secretions. And so we used mucolytics to help thin these out and make it easier for him to clear. So things like saline nebs, carbocystine, acetylcysteine. If it had been a different situation where he had really high volume of very thin secretions that he was struggling to clear, for example, if he had a poor cough or couldn't really use suction, then we might have thought about using an antimuscarinic. So options would be something like a scopoderm patch, or you can use glycopyrronium solution for injection, and you can give it either orally or via someone's feeding tube. If someone was coming more towards the last days of life, we might think about using a syringe driver. So you can put either hyoscine butyl bromide or glycopyrronium into a syringe driver over 24 hours. Particularly thinking about a patient in the last days of life, actually what we find most effective is repositioning, so high side lying with the patient's head tilted to one side, gentle suctioning if appropriate and tolerated, explanation and reassurance for patient and family fan therapy can be really helpful to reduce any associated breathlessness. And then also using medications to help reduce any respiratory distress because of the volume of secretions, so things like morphine and midazolam. For Mr. X's pain at this time, he was having PRN Oromorph down his rig, which was effective. And so we, over a course of a few days, worked out how much he was requiring in 24 hours and then converted this over to a fentanyl patch. So I've just put kind of the equivalent oral morphine doses for buprenorphine and fentanyl patches there. These are strong opioids, and when we're starting a fentanyl trial, that's the equivalent of 30 milligrams of oral morphine in 24 hours. So you need to make sure that someone is tolerant of those sorts of doses before starting. It's really important to think about the right route when we're prescribing analgesia in this patient group, and also thinking about use of adjuvants early on to reduce kind of side effects from high doses of opioids. For Mr. X, there was kind of the added layer of complexity that we knew he had a history of substance misuse and was quite a vulnerable patient in where he had been living before and the fact that he was now homeless. So all of these things were kind of factored into our decision-making process. So in terms of thinking about kind of advanced care planning at this time, one of the big things was around whether or not his palliative chemotherapy should continue. And the feeling from the oncology team was actually that the risk of death from severe sepsis due to the ongoing risk of aspiration pneumonia because of this tracheoesophageal fistula was extremely high and outweighed really the benefit of continuing with the palliative chemotherapy. We had these discussions together, myself and the oncologist, with the patient to kind of help come to the right decisions around stopping treatment. A second really important part of planning at this stage was he'd already presented with one bleed but had successful embolization, but we were aware that he was at risk of further bleeds. And it was thinking about what he would want to do in an emergency situation. So Mr. X felt really safe in hospital and was well known to the staff on the ENT ward. He was very clear that he would want re-escalation to hospital, and that would be for management of an acute bleed, for consideration of re-embolization if that was possible, but also if he was to get an infection in the future at this point, he felt that he would want the option of having that treated in hospital. But he did agree that CPR would not be in his interest at that time. So these conversations took place over the course of several weeks, and we did quite a lot of joint working to try and make sure that we had quite a robust respect plan at that time. I think it's just really important to remember that these aren't just a one-off conversation, and as the patient's situation evolves, those respect plans or whatever is used locally will need to be reviewed and updated, particularly when we're changing from healthcare settings. It's just also really important to note that the language we use, what's applicable in hospital, for example, ward-based care, is very meaningless in a hospital, in a community situation. And then finally, a big part of what we were involved in was thinking about discharge planning. So we involved the complex discharge team to think about where we go from here. And he was discharged back into the community, but with specialist palliative care follow-up and safety netting. So Mr. X was discharged on his first admission to a care home, and he managed about 3 weeks before he re-presented with further oral bleeding. He wasn't immediately referred back to our team, but one of the ward sisters referred him a couple of weeks into this admission in a pain crisis. So unfortunately, although we'd started a fentanyl patch on the previous admission, which he'd been discharged on, this had not been re-prescribed. There was also quite a lot of issues with alcohol misuse and behaviour from his friends and family in the care home, and that placement had now been closed and the patient had become kind of blacklisted. At this point, we could see a deterioration in his condition, and we felt that he was probably entering the last short months to weeks of his life. So in terms of managing his physical symptoms, so he underwent a further CT angio, and unfortunately at this time there was no further embolization point that could be identified. He was given IV tranexamic acid, and then this was changed to his rig once the bleeding had stopped. He had had kind of crisis dose midazolam prescribed, PRN on his drug chart, but there was no upper limit of how many times this could be given, or indication as to why it should be given. And unfortunately, it had been given on several occasions by the nursing staff for emotional distress. When we got involved as a palliative care team, we felt it was important that crisis dose was available, and we'll talk a little bit more about planning for a bleed in a little while, but we felt it was important that we limited how many doses could be given and making sure there was a real clear handover to the nursing team about when that would be given. In terms of his pain, we restarted his fentanyl patch, and this was actually titrated. We also introduced some pregabalin because he was now complaining of really severe paroxysmal ear pain, which we felt probably had a large neuropathic element to it. And again, this was titrated with good effect. There was quite evident visible facial changes, and this was causing the patient a lot of distress. We spent a lot of time giving him emotional support, and we were very lucky that the ENT ward were able to facilitate a side room for Mr. X, which really helped. So at this point in the patient's second admission, it was really important that we reviewed those ACP and treatment escalation decisions that we'd had on the first admission, because clearly his clinical situation was changing. We talked about what kind of active interventions could and couldn't be offered if a further bleed was to happen, and whether or not coming back into hospital was the right thing. Again, Mr. X expressed how safe he feels in hospital, and also that this was his preferred place of death. He felt that he was, really well known on the head and neck ward, and this is somewhere that he'd want to be. We completed a really robust respect plan reflecting his wishes, but also created a separate treatment plan in the event of a major hemorrhage. And this was in place both to be used on the hospital ward, but also when he was discharged back out into the community. He was discharged this time to a different nursing home with fast-track CHC funding and a referral back to the specialist palliative care team in the community, although he now fell under a different team. Securing fast-track funding was really challenging, particularly because of the patient's complex social background, and the only way we were able to do this was with really close working with the ENT consultant to support us in helping the ICB recognise that he had complex medical needs that could not be met through the normal homelessness pathways, which is what they were recommending. So just over the next couple of slides, I've set out some of the really key things to be thinking about when a patient's at risk of having a catastrophic bleed. So the most important thing is if a patient's been identified as at risk, then it's about, can we reduce that risk? And then how do we communicate that risk, both with staff, loved ones, and the patient themselves? And this requires really sensitive communication at the right time. But it is really important that we do discuss that risk with patients and their loved one, because it will impact their decision-making about where they might want to be cared for at the end of life. It's really important that when we put a plan together, it's documented clearly and shared amongst all of the appropriate teams. It's also really important to make sure we have the right equipment available. So during an acute catastrophic hemorrhage that is felt to be terminal, the most important thing that we can do is stay with the patient. If we're in an acute environment, then we should be able to have help and maybe do some other interventions to reduce distress. So I think the thing that people most often think about is the prescription of midazolam to reduce the patient's awareness. As we know, if it's a true catastrophic hemorrhage, then it's likely to be over very quickly, and we may not have been able to draw it up and give it in that time. And so we always say staying with the patient is the most important thing that can be done. These events can be very traumatic for both the loved ones involved and the staff. And so palliative care teams are always happy to facilitate debriefs to discuss and reflect on learning. So my final contact with Mr. X was a couple of months later, where he was readmitted with drowsiness and low SATs. He was admitted under medics and treated for pneumonia. His RIG feeding was paused. He was hypercalcemic on this admission, which was treated. Each time his RIG feed was started, there was evidence of aspiration. The patient was very distressed by the feed stopping and really was scared about starving to death and feeling hungry. He continued to have oral bleeds with significant hemoglobin drop, and he continually complains of a feeling of suffocation due to the sensation of his tongue swelling and displacement, and there was very clear visible facial changes. We now felt that Mr. X was moving into the very last weeks and days of his life, and so a different joint approach was taken to his care. So we worked closely with the enteral team, reducing his feeding rate and then stopping it once he was no longer conscious. And there was lots of ongoing discussions about when and how we should stop and reduce his feed. We managed his increasing anxiety and agitation with a syringe driver with morphine midazolam. This was in addition to the fentanyl patch, which we just left on in the background. Anticipatory medications were prescribed, including the catastrophic midazolam dose, and the catastrophic bleeding plan was put in place. We again revisited those advanced care planning conversations and talked about where he might want to be for end-of-life care. He very much still had that preference of staying in hospital. We explored going to a hospice to see if that would kind of offer that safety feeling, but relieve some of the pressure on the acute trust. But unfortunately, they couldn't support an altered airway. So he remained in hospital for end-of-life care. He had a few small bleeds, which were self-limiting in the last few days of life, and he died very peacefully about 3 weeks after that final admission. So I really hope that this case illustrates kind of the importance of joint working between our specialities to address some of the really complex symptom and psychological issues we face with these patients. I've just included some links to some really useful resources. So if anyone doesn't know who Catherine Mannix is, I would really recommend watching a YouTube video or looking her up. She just gives some really useful language for how to talk to people about dying, because I think that's something that healthcare professionals can find very daunting. I've also just put the links to the West Midlands Palliative Care Guidelines and some of the specialist guidelines for management of a major bleed. These are free to access on the internet. Thank you very much for having me to talk today, and I'm very happy for any questions to be emailed to me. I think the organisers will share the details with you. Thanks a lot.